Can you see my screen?
Yes, sir, it's visible.
Yeah. Good afternoon and a warm welcome to everyone. Professor Dr. Atul Goel, Simi, entire NCDC team, and all the participants across India. I'm going to give a brief update on the Mpox situation. And as Simi already mentioned, that this is now a PHEIC, Public Health Emergency of International Concern. So if you see, this is a viral zoonotic disease. It has a lot of history back. In fact, it was research in 1958 with the monkeys. That's how it got. But the first cases that actually came into light was in 1970. And this is a virus. It's a double-stranded DNA virus. It belongs to a family, Orthopox. It's Orthopox virus. It's a Pox viridae. And initially, there were two basic strains that were there. One is the Congo Basin strain, and then the West African strain. Originally, the Congo Basin strain was the one that caused severe disease and also death, high death. And later, the West African clade also reached across to all the world in many countries. That led to the 2022 outbreak. Now, if you go and see so now we call it clade distribution, clade 1 and 2, which was originally the Congo Basin and the West African strain. What is a clade? Clade is just a group of organisms who are closely related to each other. It is like a branch of a family tree, like one ancestor and descendants, and therefore they are all closely related to each other. So clade 1, they're related to each other. Clade 2, they're related to each other. Initially, the clade 1 was the one that caused the severe disease, and clade 2 was the West African, which went across the world. And we have nearly about 116 countries that were affected from 2022 onwards. The main problem that we see is the central part here, where you see a red color. And we have in Africa more than 15 countries which have been affected. And since 2024, we have 12 countries being affected.
Excuse
And
me, sir. Sorry to interrupt. Just requesting to make it a full screen, sir. Audience will not be able to see.
Share from presentation.
1 minute.
Yes, sir.
Can you see now?
Yes, sir. It's full screen. Thank you, sir.
Yeah. Okay. What you see in Africa is the red area countries. And here you see the clade 1, which is rapidly spreading. Initially, there were 15 countries totally affected. But since 2024, we have 12 countries affected and 9 are currently active right now. So this is the situation which is there. Now, if you go back to see, so these 9 affected countries, you can see in red right now, there is active Mpox transmission going on. But what we see is since July, August, there is a new clade that is 1B, which has come. The original one is 1. So original one became 1A. And then we had a new clade, which is 1B. The issue with this is that it was rapidly spreading through sexual contact, and it started in the eastern part of the DRC Congo, and then of course it has gone into surrounding countries like Burundi, Rwanda, Uganda, Kenya, Cote d'Ivoire, which is re-declared as active. And also we have suspected cases in South Sudan, where samples are being tested, and picture looks like the cases are spreading. So that is a concern for us. And what we know is the clade 1B, which is the new one, it is more severe, and it's a more severe disease and also causing death. Now, since in the world, we have more than 100,000 cases from 116 countries. And the concern is the DRC Congo, where in Africa, we have now more than 15,000 cases and more than 500 deaths. That is just this year alone, within 6 months. And therefore, there is a lot of concern, and that is why they have declared this public health emergency of international concern. We also have some cases outside of Africa. I'll come to that in a short while. Now, this is how the clade is spread. You can see right now the color of light green and light yellow, clade 1 and 1B. So in DRC, we have a mixed picture of both clade 1A and 1B. And therefore, you can see the 1B from the eastern part of DRC. It is also going into Uganda, Kenya, Rwanda and Burundi. Burundi has been affected the worst of the countries, and you can see the clade 2 in the other countries that are going on. Now, the typical picture is if you see the age distribution, this is the endemic countries which had the original strain, which is the 1A. So in DRC, you see that many children are affected in the original strain, that is the 1A. But the first cases of 1B started in Kivu. And if you see the picture of how it looks there, you see less children are affected, but it is more affected by adults, and also both men and women, both getting affected. So this is the picture how we see here. And if you see the bar charts here, especially in May and June, you can see the high number of cases being reported from the African region. And much of it is from DRC Congo, but you can also see other countries getting affected, like this Burundi here, which is in green. In this slide, the issue is that we have issues with diagnostics, and out of the suspected cases, only about 40% of them are getting tested. So it is still the tip of the iceberg, and there are many cases not detected by things. So the case load is definitely very high as of now. And we also see that in the later part of June and July, of course, there is incomplete data. So once this data comes, then we get a better picture of how it is happening. So available evidence on clade 1B, what we are learning is that it emerged in 2023. It is spreading in the eastern DRC since September 2023. And what we know is that it spreads more through sexual contact, and it is being amplified by extended networks, especially the sex workers who are there. And what we also know is that there is sustained community transmission, which is going on for now more than 10 months, and it is person-to-person transmission. And we also see the picture more severe than the clade 2, which affected the countries across the world. But there are a lot of things that we don't know about this virus. So we are still trying to understand much about the virus. The first cases of clade B, where exactly it came from, is still unknown. If it is actually more severe than clade 1A, we are still learning that transmission picture. Though we know that it is spreading through sexual contact, is it the data is still incomplete, and we need to get a better picture of this. Of course, things like incubation period, secondary attack rate, serial intervals, um, we are still learning much more about this disease. And that's why the WHO has declared this a public health emergency of international concern. Now, if you see some of the cases in the WHO Southeastern Asia region, you can see that we do have cases. This is actually clade 2, which is in Indonesia. Last year, we had cases. And also in Thailand, we have cases in the last year, and there were more cases in the 33 to 37th week. And cases continue to be reported even in 2024. And in the week of 12 to 18th August 2024, we had 2 cases being reported from Thailand. And what we know recently is this suspected case of monkeypox. Now it has been declared as clade 1B. There was an alert. So this was a patient, 66-year-old European male who traveled from Africa. He was reported to the system on 14th of August. He developed fever on 15th and was hospitalized. Uh, of, and the Thailand has done close contacts. They have identified 43 contacts, and public health advisory has been given to travelers from Africa who should monitor their symptoms, especially fever, rash, and any swollen lymph nodes for 21 days, and seek medical attention if symptoms develop. So what are the key high-level WHO activities that are going on in August? As of this situation, there is an ongoing coordination and support through especially the global Mpox partnership. It has been regraded as acute emergency of grade 3, August 2024. Across the countries, they are strengthening the incident management support team, and there is an extension of the standing recommendations of Mpox, which I will come to. And especially since the vaccines are short, and we need more vaccinations vaccines across the country. So emergency use listing for Mpox vaccine is also started. So what are some of the main challenges at various levels, global, regional, and local levels? We know the virus is spreading, and it is a new strain. And we know that the genetic information that this mutates quite frequently, and over the period of time, we have seen more than 50 mutations that have happened. So that is a concern for us, that it can become more virulent and more transmissible and cause severe disease. So that is a challenge. Then the second challenge is of the limited surveillance and reporting. So many countries are grappling with case identification and reporting this case, and then lab diagnostics availability, and confirming the case. So this is a challenge. There are challenges in communicating risks and engaging at-risk communities, especially, of course, the sex workers, which is very difficult. The other challenge is that in immunocompromised persons, the virus is more severe in disease, and also the death is more in such persons. So especially in the African context, where there are high HIV virus, we also have high rates of HIV persons getting affected, and more severity and death in these persons. As I've said, the high cost of diagnostics, which is a main concern for us. and the availability and access of vaccines, which is very challenging. Now, if for the vaccines, WHO has recommended 2 vaccines for Mpox, which is the one that is the MVA-BN and the LC16. So these are available and quite effective in containing. It should be given as soon as possible. Then the standing recommendations, which were done from August 2023 to August 2024, which is extended. There are 7 components here, which we need to look at countries. Of course, do we have national monkeypox plans in the country? So it needs to evolve. There definitely needs to be strengthening of the surveillance and health facilities getting the case definitions of the suspect cases and reporting the case. I think this needs to happen. And the main component is also the laboratory, which needs to be strengthened. Communication and engagement. Of course, we here look at risk communities and especially the who can be effective, like the dermatologist or STI clinics or the NACO, etc. So how do we engage these groups? That is something there. Research is one area where we need to look at. Provide travelers with information, optimal clinical care, and access to safe vaccines. So these are all the 7 components, and this thing has continued even for 2024. Now, on 19th August, the committee met, and there were temporary recommendations issued to the countries following the advice declaration of the PHEIC. And here we have 9 components where advice is given on all the 9 components. The link is given here, which you can download. I will not go into details of this recommendations. Of course, it talks about emergency coordination, how to improve for the surveillance and laboratory diagnostic capacity, clinical care, international travel and trade, vaccination, risk communication and community engagement, financing and integrating Mpox into some of the existing health programs, such as the HIV or NACO, addressing research and how these cases are also reported to WHO. On the right side here, we also see the links. The standing recommendations still stand of the last years. It has been extended. We also have a strategic framework for enhancing prevention and control of monkeypox, which was released this year, 2024 to 2027. And it talks about coordination, clinical care, countermeasures, access to countermeasures. So the 5 C's, so these are some things, communication and community engagement. So these are some of the things the framework discusses. I will not go into details about the framework. The links are available for downloading. Now, of course, here, as we saw that IDSP is also documenting the cases. We have laboratories in India. So we mapped this places which we received. There are total 35 VRDL laboratories across the country. And strengthening of the lab network is happening. And we definitely need to ensure that the case definitions reaches the key health facilities and also the people who are likely to see some of these cases. So this is my last slide. Of course, we have a lot of information at the website. This is also the WHO INT India website where resources are available. You can download the link and also go and see. There are a lot of materials also available which can be translated into communicating materials. We have a Facebook page, Instagram page, and also the WHO India web page. So these materials can be used for dissemination appropriately. So I'll stop here and hand over to NCDC.
Thank you so much, sir. Thank you for the overall global update around the Mpox and what the WHO stands for the PHEIC and the current situation in India. So thank you so much, sir, for your valuable insights about this important topic. So now I'll introduce the next speaker. So our next speaker is Dr. Simmi Tiwari, Joint Director and Head, Center for One Health at National Center for Disease Control, Government of India. So ma'am is the experienced public health specialist, having the work in the Center for One Health for the zoonotic diseases, and one of the key areas where the epidemics and pandemics will be there over a period of time. So over to ma'am for the presentation and overview about the epidemiology and evolution of the Mpox in the country.
Thank you, Dr. Jitesh, and I again thank all the participants to joining for this webinar. So I will not be going, many of the things have already been covered by Dr. Pavana Murthy from WHO. So this is first slide wherein we can see a snapshot how the disease is presenting on the global map. So if we look at, as of now, 1,03,429 confirmed cases and 225 deaths has occurred in 121 countries. So this is really a cause of concern. And this data is as of 22nd of August. That means a day before yesterday only. But if we look at the, again, an important event which has happened in WHO, that they have declared monkeypox as a public health emergency of international concern on 14th August. So all the countries are put on alert. Same way, the IDSP, Integrated Disease Surveillance Project at NCDC, which is a leading apex public health response agency of Government of India, has put on high alert. And this is how the, all the divisions at NCDC, they have taken an initiative to join, to organize this webinar. So if we look at overall monkeypox, it has been since last 6 or 7 decades had been an endemic in the Central and Western Africa, where several species of mammals are suspected, and they are supposed to be as a natural reservoir of the virus. But if we look at the historical perspective, it was discovered way back in 1958. It has already been informed by Dr. Pavana. It was discovered in Denmark in a captive monkeys which were kept for the laboratory research. But the first human case, it was diagnosed in 1970 in Bankasuru, a Democratic Republic of Congo, and then frequency and severity of the outbreaks have significantly increased. So that causes a concern among all the member countries and all over the globe, that what exactly is leading that the virus is changing its behavior, or is it possibly due to the waning immunity since the cessation of routine smallpox vaccination? So if we gather the past experience, smallpox has been a devastating for the global community. So this is how the threat is being perceived on a global platform, that can monkeypox be as devastating as smallpox in the past? So if we look at the 2023, the global outbreak was due to clade 2, and it marked its first incidence of widespread community transmission outside the Africa. So that was the first alert that this local outbreak is taking a feature of a pandemic. So this slide has already been described by Dr. Pavana, so I will not be going in much detail. So this slide is showing overall evolution of the disease since 1958 onwards. But few of the critical features, if we look at 2003 till 2024, the outbreaks has behaved in a different manner. If we look at 2003 outbreak, the monkeypox was due to clade 2. It was the first imported case in United States of America. And if we look at the news articles, that was due to adoption by a couple in America, a prairie dog, which was a pet. It was an exotic breed of the dog. And that's how the disease was introduced in USA. But afterwards, there were consistent outbreaks were reported in the Africa, and to which the virus is indigenously belonging. And then in 2005, Mpox suspected case was again reported in DRC, and more than 300 suspected cases with high case fatality rate, especially among children, and those without history of prior smallpox vaccination. So this was again alert for the local community and for the Central Africa. And then in 2017, the monkeypox re-emerged in Nigeria with 200 confirmed cases, and several deaths has happened. And then re-emergence highlighted the potential of Mpox to spread in the urban settings. So this is how from the rural to the urban, due to various risk behaviors among those African communities. And then travel reported cases were reported in 2017 in UK and Israel. And this highlighted the potential for spread through the international travel. So again, an alert was there on the global platform, and again showing the importance of zoonotic diseases transmission beyond the countries. And then in 2022, if we look at the nature of the outbreak, that was the sudden and rapid Mpox outbreak in 110 nations, including Europe and America, and 87,000 cases and 112 deaths were reported across the globe. The outbreak primarily affected the men having sex with the men, MSM community. So this was a little stigma that was a little bothersome for the entire global community. That again, the outbreak is being linked to a certain community or certain risk factor. The clade responsible was found to be clade 2B, B1 lineage as the dominant strain, potentially originating from the Nigeria. And then WHO declared PHEIC on 23rd July 22, but it was again receded back. So that was a policy decision at the level of WHO. Then if we look at the current outbreak 2024, the emergence and rapid spread of a new viral strain, which is a cause of concern. But again, the strain is emerging from the native land of virus, that is the DRC. The clade is now nomenclature has of clade 1B. But it is causing significant deaths. Case fatality rate is higher as compared to the previous clades. And monkeypox is detected in the countries which never had previously identified cases. So now there are many questions to be answered, that how the infection is spreading in the other countries. And if you look at in 2024, over 100 confirmed cases and more suspected cases are reported in Burundi, Kenya, Rwanda, and Uganda. And WHO then declared it on 14th August 2024, this Mpox as a PHEIC, or Public Health Emergency of International Concern. The outbreak dynamics, if we look at critical information about the outbreak dynamics, initially the outbreaks behaving as a localized with a limited secondary infection. But notable outbreaks were still in the 1980s, 1990s. They were linked to the civil unrest. and disruption of the healthcare services, leading to the increased zoonotic exposure. But 2022 outbreak that marked a significant concern to the global community because the age distribution was among the economically productive age group, that is between 27 and 41 years, and high concentration of cases was noticed in this age group to the extent of 79.1%. There was a gender breakdown. Majority of cases occurred in males. HIV status, that was a significant cause of concern because 52.5% of reported cases were HIV positive. Sexual histories, 96% of infections was among the man who had a sexual activity with the other man, and rural and urban outbreaks in the DRC. The outbreak was primarily in the rural, but again the barrier was crossed, and the outbreak was noticeable in the urban areas as well, particularly in the mining regions. In 2022 January, 99,000 cases were reported with 207 deaths. The peak at that time, that means in 2022, was 6,000 in 1 week. And approximately 116 countries were reported. So now the data has not been collated for the 2024 outbreak, knowingly, because we are still studying that how the because we don't understand that the peak is yet reached, but it may be coming soon, and we are hoping that we will be having more data to share with the current outbreak. So coming to the epidemiology of monkeypox or the Mpox, the agent has already been described in the previous slides. So again, it is a double-stranded DNA virus belonging to orthopox virus, similar to smallpox or the variola virus. If we look at the environmental stability, it can remain viable on the surfaces for the extended periods, contributing to its potential for fomite transmission. High pathogenicity, it is capable of causing severe disease, especially in the immunocompromised individuals. Incubation period is found to be 6 to 13 days with a range of 5 to 21 days. Period of communicability is 1 to 2 days before the rash to until all the scabs fall off or get subsided. This is electron microscopic picture of Mpox virus. This slide has already been shared by my WHO colleague, Dr. Pavana. So we can see that in certain region of DRC or Zaire, which was historically known name of that country in the Central Africa, we can see the overlapping of the clades, Congo Basin as well as West African clades. But I would like to share this slide because this is showing what are the difference between the different clades. Central African, that is the Congo Basin, and the current clade, clade 2 with 2A, 2B and 1 in the West African. The epidemiology of clade 1, if we look at it, is known to cause the local outbreaks with high mortality. But clade 2 is more widespread outbreaks are happening, but lower mortality, but higher spread. Case fatality by clade 1 is up to 10%, but due to clade 2, it is up to 6%. Transmission, limited human to human transmission. And if we look at the clade 2, there are higher transmission significantly noticed in 2022 outbreak. Host range for the clade 1 is broad. Various mammals has been incriminated for having this as a reservoir host. But for the clade 2, the reservoir or the host range is narrow, mainly limited to the non-primates as well as humans. Molecular traits, the clade 1 is highly virulent and has potential of immune evading property. But the clade 2, on the other hand, has mutations enhanced transmission with a relatively lower virulence. Immune response for the clade 1 is found to be strong. Often it causes severe pathology, and clade 2 is relatively milder, although it evades the detection. So there could be a kind of window period where we can miss the cases to be detected by routine diagnostics. And if we look at the pathogenesis for the clade 1, it causes a systematic damage. Multiple organs get affected in a rapid scenario. especially in the immunocompromised patients. But in the clade 2, the lesions are found to be localized with milder symptoms. So this is a slide wherein we have attempted to show the propensity of the different clade having transmission properties. So if we look at the clade 1, the major clade 1 and clade 2A both have the animal reservoir, and to a limited extent, both the clade 1 and 2A, they have zoonotic transmission and human-to-human transmission. If we look at the reservoir host, there are still many gaps in the knowledge, but whatever evidence is available, we know that the rats, squirrels, and non-human primates, that is monkeys and apes, they are found to be natural reservoir of this virus. Rope squirrels, Gambian pouched rats, African dormice, and non-human primates. So these are the major reservoir for the virus. There has been a study of 2023 wherein 240 rodents in Baisela rivers and 2 other in South states were found, 5 animals from 3 species that had antibodies and DNA of orthopox viruses, the genus to which the Mpox belongs. So, this is a kind of this is how the significant public health concern is there. Looking at the a wide range of wildlife reservoirs existing. This is a slide wherein we have attempted to show that how the things are happening across wildlife towards the major cities. That is how the virus is traveling. The natural sylvatic cycle is being maintained in the rainforest, and then the virus is spreading from the reservoir host through zoonotic route from the animals to the humans, and then how the virus is evolving to cause pandemic across the globe. So there are multiple routes of transmission. Human to human transmission is basically happening due to contact with the body fluids, pox lesions or the vesicular rashes, and also there is limited evidence through intact skin and mucous membranes. There has been certain studies which are claiming that it is a respiratory droplet acquired infection. Sexually transmission has a good proof of concept that because the outbreak has happened in 2022 in man having sex with man, and mother to fetus is also limited evidences there. Animal to human transmission is well established. Infected animal bite or scratch, butchering and/or consumption of bush meat. The consumption of bush meat has been incriminated a significant source of few of the local outbreaks which were happening in the Central Africa. And then direct contact with the body fluids or lesions or the contaminated material. Fomite transmission is real cause of concern. Again, giving due importance to the public health measures, because virus has been shown a significant length of presence on the contaminated clothing as well as bed sheets. The risk assessment for the different population category at the community level and the healthcare facility level, if we look at the probability of the infection among the sexual partners is high, but in the general population at the community level, the probability of transmission is very low. But if we look at the propensity of transmission in with the infected pet, that is a very high. Overall risk is considered to be moderate in the sexual partners. General population, again, it is low, but high risk in the high risk group, it is moderate. If we look at the healthcare facility level, healthcare workers, if they are protected, they are there is a very limited likelihood of getting infection, but the likelihood of getting infection is very, very high if the healthcare worker is unprotected. That means if they are not using any personal protective, if they are not taking any personal protective measures. But in the laboratory workers, if they are unprotected, the probability of getting infection is very, very high. The risk is basically determined by two main factors. Probability, how likely it is for someone in that category to get infected, and impact, how severe the consequences of infection could be. And the combination of these factors, they give the overall risk rating for each category. If we look at the current outbreak, a significant proportion of the cases are reported from the pediatric age group. The risk factors for the pediatric age group is being malnourished or immunocompromised children, or there is a possible explanation that it may be attributed or may not be, because the evidence is very limited, because the children are little immunologically naive to the virus. And for the older age group, there may be a cross immunoprotective effect due to the previous smallpox vaccination. So these are just hypotheses which are being rolled out on the medical fraternity. Modes of transmission among the children is spillover from the animals, household transmission, infant transmission has been hypothesized from the mothers, and direct infection from animals to meat in the older children has been documented in few of the scientific literature. Approximately 50 to 60% of the cases in children has resulted from person-to-person transmission. Means if a family has an infected case, the children living in that family has 50 to 60% propensity of getting infected. But children, due to limited immunity, they have more prone to have secondary bacterial infections, severe skin infections, dehydration, pneumonia, encephalitis, ocular complications, and long-term sequelae. They are more, children are more prone to have these long-term sequelae or other complications due to disease. I will not go in detail of the molecular epidemiology because that would be covered by the subsequent speakers. I think Dr. Pragya madam, she would be talking about this. But I would like to highlight few of the knowledge gaps in the epidemiology and disease transmission. Are the cases of monkeypox that are subclinical, where individuals are infected, but they do not show the symptoms. So there is, by virtue of transmission pattern of the disease, it is highly probable that the cases may be subclinical. But that could be a very negative aspect of this virus if the cases have been subclinical. Because if we look at the smallpox history, the major reason why we were able to eradicate the smallpox, that was the very overt clinical nature of that disease. But if Mpox is having subclinical nature, then that could be a real challenge for all the countries and all the public health response agencies. There is a question whether there has been ongoing undetected, unreported, misdiagnosed monkeypox transmission. Again, this is linked to the subclinical nature of the disease. But once we are noticing the foci in the non-endemic countries, so this hypothesis seem to be a little weighted in the positive sense that yes, there may be subclinical cases. So we need to find some of the screening test in the population. So that is again a public health response that has to be taken. So again, there is a big question why this current outbreak is more evident in the children. What are the risk factors other than having a close contact within the family members? Is it possible that the virus has already spread to the pets or the wild animals? In the countries where there has been no reported case. So is there any kind of sylvatic cycle is going on across the countries? That is a big question. So giving a requirement for having a surveillance, a strategic surveillance in the pets or the wild animal species. Again, there is one question that is the virus is having ability to be persistent in a latent state within the body. That means does it has a property to be dormant somewhere in the body? But if we look at the virus, it multiplies in the cytoplasm. So it is not a virus which get latent in the dormant nerve roots. So that is again a question to be looked at. And again, a big question, how the viral genome is going to behave in the future. And is the virus has potential to behave as devastating as smallpox or causing a global threat? So these are the few knowledge gaps that has to be answered. But these are only few, but there may be many more questions to be answered in the time to come. So with this, I end my presentation. Over to Dr. Jitesh. Thank you very much.
Thank you, ma'am. Thank you for the valuable insights on the epidemiology of the Mpox virus and how the epidemiology is unfolding over a period of years, and how much we need to know about this virus and the new clade that is spreading in the African countries. So with this, we will move on to the next topic. That is, we would like to know more about the disease, the clinical symptoms and the differential diagnosis, as well as the available treatment modalities. So I will request Dr. Manish Soneja, sir. Before that, I will introduce our next speaker. Our next speaker is Dr. Professor Manish Soneja. He is a professor at Department of Medicine, AIIMS, New Delhi. Sir is having a wide experience and having the more than 195 publications. He is the expert group member of national guidelines for various vector-borne and diseases as well as influenza. And he is the part of the expert panel in the AIIMS COVID management and guidelines and algorithm during the COVID pandemic. And he has been the winner of the AIIMS Excellence Award. So I will request now, sir, to share his presentation and start the presentation. Over to you, sir.
Thank you. Thank you, Chair, and the organizers for having this important discussion. So I'm trying to share my screen. Am I audible?
Audible.
Yes, sir.
A very good afternoon to all the colleagues across the country who have joined today on this discussion. So my part is Mpox, clinical features, differential diagnosis and management. The first reaction that the public is having, and there are many inquiries that are coming in OPD currently, is that are we headed for another lockdown? Is Mpox, which is still colloquially being called monkeypox, is it going to cause a pandemic like SARS-CoV-2, COVID? Well, the pandemic potential is higher for RNA virus like SARS-CoV-2, but Mpox is a DNA virus. So it doesn't have those mutations that occur while replication in an RNA virus due to lack of proofreading mechanism. So unlikely that it is going to cause a COVID-like situation. But if we have a look at the public health emergency of international concern that has been declared since 2005, its inception year, it has been invoked 8 times. And as we see, so it was first for swine flu, and then we had polio, we had Ebola twice, we had a Zika virus, we had a COVID, and now this is a monkeypox that was clade 2, and now monkeypox clade 1. So if we notice closely, all the viruses for which PHEIC has been declared till now were RNA viruses. This is the first time a DNA virus, a public health emergency, has been declared. Now, these are subtle differences. Due to higher rates of mutation in RNA viruses, they have a pandemic potential, which is quite unlikely for a DNA virus like Mpox. And also, the vaccines, whenever they are produced, they are likely to be much more effective in a DNA virus, as compared to a RNA virus. Similarly, if we do get a treatment option, a drug, an antiviral, they are more likely to be useful over a very long period of time because mutations happen much less frequently in DNA viruses. But why are we discussing Mpox today? So there are mutations which sometimes are very important, causing differences in transmission rates than what was it occurring previously. So in this case, what we are looking currently is the ApoBec3 mutation, which is probably driving the current increase surge in transmission and disease severity with Mpox. Now, before coming to the clinical features, let's see how this pathogenesis explains the clinical features. So as of our current understanding, direct contact is the predominant mode of transmission. For clade 1, possibly there is also droplet transmission, fomite-borne transmission, which is important. So once the infection happens, this primary viremia, the virus goes into the lymphatics and gets lodged in there. It replicates there. Then during secondary viremia, it goes to the different organs, liver, heart, brain, and to the skin, presenting as these manifestations. So the clinical features happens during this secondary viremia phase. So traditionally and classically, what we have been taught that incubation period for Mpox is 4 to 21 days. During the 2022 outbreak, the calculations were median of 8 days. And the clinical features initially were prodromal period of up to 5 days, which is like any viral fever with fever, body aches, backache, fatigue, and a rash, which appears on day 1 to 3 of fever onset and then lasts for 2 to 4 weeks. Now, this has been the knowledge which has been gathered over 50 years of Mpox, which has been endemic in the African countries. But then we had an outbreak in 2022. And we had some surprises. So rash is universal, nearly seen in all patients. Fever was missing in 1/3 of the patient. And this data, which has been collected symptomatology across during the entire period of the illness. It's not the presenting features. So 1/3 of the patients do not develop fever during the entire course of the illness, which is a very important factor, particularly considering that a large number of patients presented with features of proctitis. That is, the virus was causing the lesions in the rectal and perirectal region. So patient were presenting with rectal pain, rectal bleeding, tenesmus, blood in stool, and they didn't have fever. So any patient who is not presenting with fever and coming with features of proctitis, they can only be suspected if our level of suspicion is high. So knowledge about this variation in symptomatology is very important for us. But now 22 is gone, we have 2024 outbreak. What do we expect now? As discussed, this is being caused by a new variant, clade 1b, but this has been endemic in the Congo region for a very long time. So we really need to see the data that has been emerging from there over the past 5 decades. Now, this clade outbreak began in September 23. Increasing number of cases have been reported. And as the virus spread further, the affected groups are changing. So more children are getting affected, with the virus also taking hold within households and other settings. So probably this is pointing towards beyond direct contact to fomite-borne transmission that we need to look into, and we need to be careful about while we are going to see these patients. So if you look at the case fatality rates that has been coming from Congo, 2023 fatality rate 4.5%. First 5 months of this year, fatality rate 4.9%. So these rates are quite high. We have to understand the reason, and there may be local factors also playing factor like malnutrition, HIV rates, availability of supportive treatment. In this current outbreak, the disease has been at least reported beyond Congo from 4 countries, Burundi, Kenya, Rwanda, and Uganda. And no deaths have been reported as of yet. I last seen this data on 22nd of August. Mind you, this is just only a few hundred cases, so we need to keep an eye here. Again, Congo data to give us an idea what to expect. So 852 patients first 5 months of the year. So predominantly age group being affected are children in terms of numbers, 5 to 10 years, 20. So 5 to 40 years is this bracket where majority of the cases are being reported. And this is also the mobile population. So isolation and all is going to be a challenge in this group of patients. Now, what is the case fatality rate? If we look across ages, the overall is 4.9%. But if we look closely, maximum fatality is in less than 1 year, and then it gradually decreases as the age increases. In adults, it is less than 3%. So this is data from Congo. And on top of this, we have this report last month which came out, which has reported high rates of miscarriage and stillbirth among pregnant women with clade 1 Mpox. Now, to be sure, this is just a very small data set, 8 patients, 4 of whom had miscarriages or stillbirth. And this was shown as 50% fetal mortality, and alarm bell is being set out. But the paper doesn't really contain data regarding various other causes which might have led to stillbirth. But so definitely this is not a proven factor, but yes, the flag has been raised and we need to keep a watch on this aspect also. So regardless of the clades, the clinical presentations may be variable, fever may or may not be there, the distribution of rash may be different, but rash will be there in nearly all the patients. So, and most of the patients will come to us inquiring about a rash. Obviously, we will be looking for an epidemiological link, travel history, etc. But many a time patient may not give a very proper history. And this happened last week only. One of our patients came and said that he has an exposure to a person who has been traveling from overseas and he probably had a rash. So obviously, we do not have a definite epidemiological link, but yes, identification of a rash will help us in suspecting these patients. So what are the rash patterns seen in Mpox? It is across the spectrum. First, we have a flat discoloration macules, which proceeds to papules, and then we have vesicles, clear fluid. When we have turbid fluid, it becomes pustules. And majority of patients will present to us in this vesicular pustular phase. Because you see, only 1 to 2 days in this macule and papule phase, and a large amount of time is spent in this vesicular pustular phase, and most of our patients would thereby come to us with a characteristic vesicular pustular lesion, which subsequently crust. After crusting, there will be itching. Prior to that amount in this phase, usually patient complains of pain, and then obviously it goes off healing, which may take 2 to 4 weeks. So characteristic rash is a well-circumscribed erythematous vesicular pustular lesion, which often develops umbilication. So in our setting, the closest differential probably would be varicella. Sometimes this patient may also present with an enanthem, that is, the rash may first appear in the mouth. Then we might have a differential with HFMD because this is occurring more in children's. So let's see some of the rashes in Mpox. So here we have an ulcerated lesion on the upper palate. So pharyngitis, this tonsillar exudate, this is also described in an Mpox patient. So oral examination is must. Very commonly, hands are involved, and this is going to help us in differentiating from some other differentials, common differentials. So you see macules, all macules, same stage in hands and fingers. We might have an isolated single erythematous pustular lesion in groin region, a vesicular lesion on the forearm, and again a pustular lesion. So it may present with 1 to thousands of lesions. Average number of lesions in the last outbreak in 2022 was 6. We'll have to see how it behaves this time. So number of lesions varies from very few to thousands, and classically what has been described over the last 50 years that the rash typically appears first on the face and then spreads downwards in centrifugal distribution, and it tends to involve the palm and sole. This is very important. However, in 2022, we found that lesion can appear anywhere in the body, and most frequently involved region was the anogenital region. 73% of people had rashes in the anogenital region, while trunks and limbs was only 55%. So distribution of rash was different, but the characteristic of rash was not different. So we need to understand and identify from the characteristic of the rash. Also, during the previous outbreak, the data came out that it was occurring in young, sexually active males, homosexuals. So there was an concern whether this is going to be labeled as an STD. Now, this is not true, and it is being spread by direct contact during the act. So we must avoid social stigmatization, which is very important in our country. So now let's come to differential diagnosis. The patient will come to us with a rash. Most of the times, fever may or may not be there. Now, differentials will depend whether he comes with a genital rash, he or she, or a systemic rash. So last time it was genital rash. So common differentials in that setting was herpes genitalis, chancroid, and syphilis. But this time, as we have very scant data, but whatever there is, it seems systemic rash is going to be much more common. Children's and young population are going to be affected more. So common differentials in our setting would be a chickenpox, varicella, disseminated zoster, disseminated herpes simplex, enteroviral rash, hand, foot, mouth disease, syphilis, and few other non-infectious cause. So let's see, how do we identify these patients? So this is monkeypox versus varicella. So on top, we have a patient of varicella that we see so often in our practice, and we know very well from our experience that this comes in crops. These are polymorphic lesions. The lesions are at various phases of development, and palms and soles are almost never affected in varicella. This is different from what we have seen in monkeypox. Palms are frequently affected. Classically in Mpox, what has been seen, and all the lesions are in the same phase of development. However, there was certain discrepancies seen in the 2022 outbreak when it was again in multiple stages of development, but classically it has been in a synchronous single phase, a single stage of development, and it spreads from phase to centrifugal direction. So this is how we need to differentiate varicella from Mpox. Now Mpox is affecting children. So another common thing which is happening these days very frequently from various parts of our country is HFMD, children again. So we need to identify these children early and differentiate between Mpox and HFMD. Now, the main differentiating point in HFMD is that it is usually localized to hand, feet, and buttock area. Though it may be there over some other parts, knees, elbow, etc. But largely, it is very localized sort of lesion. So compared to Mpox, it was for Mpox clade 2, it was anogenital lesion. But for clade 1, mostly it is a generalized rash, macules which evolve over time to pustules and scab, and usually in single stage of development. And whereas in HFMD, these are small red spots, often with a blister in the center, which is going to cause a confusion. And these are non-pruritic, but Mpox may be pruritic, particularly during the later phase of the disease. But the challenge for us healthcare workers, for all of you who are working in the field, is to identify this rash quite early. Day 2, 3, 4, patient may come to us with this rash, and then we do not have the benefit of knowing the entire course, how the rash has evolved. So really seeing these images will help us to understand and differentiate the various conditions. Zoster. Again, in your practice, you will be seeing a lot of zoster, particularly that has a very specific setting, immunocompromised patients, patients on immunosuppressants, transplant patients. These are mostly dermatomal restricted, which in the midline, it is respected, but sometimes they may come beyond dermatomes, which is called disseminated zoster. Lesions are also characteristically vesicular. So that is something that we need to be aware of. A patient history and patient setup is going to give us a good idea about this conditions. And again, very important, palms and soles are not involved here. Syphilis. Of late, we are seeing a resurgence of syphilis. Many patients of syphilis we are seeing in last few months. And they again present secondary syphilis stage. They do present and they have lesions in palms and soles. So that is not going to help us in differentiating. And they have a generalized rash, which is maculopapular rash. Now, even Mpox in initial stage would be maculopapular. So it is not going to be that easy and that straightforward for us healthcare workers working in the periphery, seeing the patients too early. So it's important to have a follow-up to advise properly during this period how the patient needs to isolate. And vesicular lesions are very uncommon in syphilis. Vesicular lesions, whenever appears, it will give away that it is a Mpox. Now, just as I told last week, we saw a patient gave a plus minus history of some exposure, not very clear cut, and this type of lesion. And this is very common in during post-monsoon, post-monsoon season in our country, insect bite hypersensitivity. And this is typically more intense in children. Again, we are expecting Mpox this time to be more in children. So this is something that we might come up with. So in exposed area, this such rashes, and patient will have person will have no other prodromal symptoms, and this will be intensely pruritic. Mind you, Mpox initially the initial lesions, macular lesions, papular lesions may be confused with this insect bite hypersensitivity, but they are painful and not pruritic. They become pruritic only when they scab. So that history is again going to help, beside the other history that we take to differentiate this from insect bite hypersensitivity. So that was in brief about the clinical features and the differentials that we need to work upon for our setting. Now, management is obviously, like most of the viral infections, it is supportive only. There are antivirals, and we will touch upon that, and there are immunoglobulins as there was in COVID times. Okay, so majority of the patients would be suitable for home isolation, and we need to give precautions which are directed towards contact and droplet precautions to prevent those transmissions. So a separate room and a bathroom is preferred, avoiding close contact with other people as well as pets, as we discussed in the previous presentations. Particularly to dogs, this transmission has been documented. So it is better to avoid contact with the pets either. We will obviously, again, contact precautions for fomites. We will advise to not to share the common items, regular cleaning, disinfection with a sanitizer, and the patient himself will have to wear at least a triple mask, and certain general precautions like avoid using contact lens because it may lead to secondary infections in the eye, avoid scratching and shaving, etc., because this is going to cause secondary infections. So mind you, the most important thing which happens, which is leading to problems later on, is secondary bacterial infections on top of this viral infection. So we need to avoid the secondary bacterial infections. Now the data is coming from Congo and other countries regarding this increased death. We would be anticipating some more granularity in the data to understand what is leading to these deaths. Is this the primary vaccine disease, that is a viral disease, that is viremia, which is causing the problem, or is it the secondary bacterial infections which are coming into picture? Because then the management becomes quite different and the outcomes also become quite different. And these isolation precautions need to be maintained till all the lesions have crusted and a fresh layer of healthy skin is formed. So principles of supportive care, I will just quickly run through. Everyone is very, very well adapted with this. Skin rash, clean with simple antiseptic. Cover this with light dressing if extensive lesions are present. Encourage not to touch or scratch the lesions. Secondary infections, identify early, give systemic antibiotics or topical antibiotics as required. Genital ulcers, particularly this one is something important. So patients with proctitis, severe rectal pain, topical lidocaine therapy, stool softener, sitz bath may be required here. Oral ulcers, as we commonly treat with topical anti-inflammatory gel. Conjunctivitis, we have to be very careful and involve an ophthalmologist early if required. Dehydration must be prevented. Fever, paracetamol, itching, pruritus, symptomatic treatment, as we all do in our day-to-day practice. So this is our just day-to-day practice for any viral infections that we need to provide. Yes, what monitoring that we need to tell the patients is that the lesions are becoming more painful. They should report to us because that may tell us that secondary bacterial infection is happening, or some systemic features are coming which might be pointing towards an onset of an progressive viral disease, viremia or sepsis. So fever, unable to eat, drink, difficulty in breathing, all these features that we look for in any patients of viral disease while evaluating for complications, we need to keep a watch out for. So what proportion of patients would require admission? Now, if we look back, what happened in 2022, 13% of patients required admission in this trial involving 500 plus patients. So subsequently, systematic review meta-analysis have shown overall only 6% of patients require hospital admission. Main reason for admission was pain management and soft tissue superinfection. And also because there was no safe environment at home for infection control practices. So very, very small proportion of patients are going to require hospitalization, and this would usually be the common scenarios which require hospitalization. Having said that, we need to be very watchful in patients of immunosuppression. So there's a good amount of data in PLHIV at least. As we can see in x-axis, this is CD4 count strata, and this is the proportion of patients outpatient care. So those with a good CD4 count, majority could be managed at outpatients department. But those with less CD4 count and high viral loads, majority of them, a large proportion of them required hospitalization, ICU, as well as deaths. Deaths were reported only in those with CD4 less than 200. So PLHIV population is something where we need to be very, very cautious, because these patients may go into complications, and it may be a wise, prudent approach that if such a patient comes, then we may consider early admission. Likewise for other immunosuppressed state, but the data though is not robust in those settings, but logically the same should happen in those settings. So once admitted, what precautions do we have to follow? Standard, contact, and droplet precautions that we do. There is a theoretical risk of airborne transmission of Mpox virus, but that is very, very low. So airborne precautions should be applied in the very, very limited settings, like let's say the patient develops a pneumonia, which may be a viral pneumonia, which may be a secondary bacterial pneumonia, and you need to do a bronchoscopy, or the patient or induce a cough or sputum. So in those settings, airborne transmission is required, but largely it is a standard contact and droplet precautions, and wet cleaning methods are preferred. What we should be wearing while managing or seeing these patients is a gown, gloves, eye protection needs to be there, and an N95 mask. So this PPE would suffice for our contact precautions. We maintain some distance from the patient, 6 feet, to take care largely of the droplet precautions and regular cleaning. Now, this will take care of the nearly all the patients, since there are some antivirals available, and even WHO is providing them currently in Congo, as far as I understand. So let's touch upon that. So what do we have? This is a life cycle of the virus within the cell. So cell replication, viral replication. So we have inhibition of viral DNA polymerase, cidofovir. Cidofovir is available in India. We have been using it, though very sparingly, in complicated CMV infections. Brincidofovir is a non-toxic oral formulation of cidofovir, but it is not available in India right now. And then this tecovirimat is acting against this protein P37, which is helping in viral packing and exclusion from the cell. So this viral packing step is being prevented by tecovirimat. Cidofovir is inhibiting the replication. So obviously it has not been much used, because majority of the patients had a self-limiting disease, but some data has come from 2022. Let's look at that. So this is effect of tecovirimat on healing time and viral clearance by emulation of a target trial. So there is no randomized control trial which is published. There's an ongoing randomized control trial in US, also recruiting from African countries. So what they use a statistical method of emulation to get more sense, to make more sense out of the data from the observation studies. And what do they observe? There is no evidence for a large effect of tecovirimat in shortening healing time and viral clearance. And the use of tecovirimat should be restricted to clinical trial settings only. Okay, let's see what more data is there. So this is a systematic review and analysis, including patients from 2022 Mpox outbreaks. Let us understand these numbers are not very large. It is largely being given under setting of RCT, which is ongoing. There is some observational data, and this data has been collected, and conclusion is antiviral treatment, in particular tecovirimat, but the efficacy remains inconclusive. So there is more data which I have not shown here. Safety of tecovirimat is not an issue. It's quite a safe drug, but efficacy as of now has not been demonstrated in observational studies. Coming to the other drug. So brincidofovir, which is used more as a second line drug, cidofovir, brincidofovir, because they are toxic drugs. So this report, again, and 3 patients, and most of the reports are like this only, handful of patients. 3 patients were treated with brincidofovir. All of them developed elevated liver enzymes, resulting in cessation of therapy. So our first principle is do no harm. Second is to look for benefit. So this is not qualifying our first principle. So that we need to be very careful about. So the antivirals are not looking very promising right now. Immunoglobulins, again, there is no data. Mpox wise, sorry, this is monkeypox, it has Mpox, no data. But yes, there is some promising thing from vaccine point of view. We have a lot of experience for smallpox vaccine, and those vaccines are protective against monkeypox as well. And over a period of time, new generations of vaccine has come. And now currently the 3rd generation Genios, which is a replication deficient virus, which is the best of all of them. ACAM 2000 was being used more recently till a couple of years back. Still is being prescribed when the others are not available, but there are issues of myocarditis and other serious side effects. So for all practical purposes, Genios is the one which will be used. In India, it is not available right now, but I believe if required, WHO will definitely pitch in, and we as a country have already demonstrated the capability to design, produce, and roll out a vaccine in the time of COVID. So this is the area we might be hearing more. And someone put in a question about post-exposure prophylaxis. This is being used also as a post-exposure prophylaxis. So current recommendations of use of these vaccines is given within 4 days from the date of exposure. It prevents the onset of the disease. And 4 to 14 days after exposure, it may reduce the symptoms. And it is also recommended among those with those at high risk of exposure. So high level of vaccine effectiveness have been demonstrated after a single vaccine. It is 76%, and after 2 doses, which is given subcutaneously after 8 weeks, so it goes up to 82%. And obviously, the efficacy in terms of post-exposure prophylaxis will depend upon when it was given. The earlier it is given, higher the efficacy will be. And currently, even scenarios where it is available, mass vaccination is not warranted. So I will conclude with some messages. So we have a public health emergency. We do expect variations in transmissibility, clinical features, and complication rates with this new clade. If we compare with our experience, whatever we had in 2022, the classical rash is vesiculopustular, and all our focus should be identifying in this vesiculopustular rash. Fever and other systemic features are variable. What proportion of patients will have this, we will see in some time. So our job is obviously to trace, whenever patient comes, to trace an epidemiological link. But at times the link may not be, may be very doubtful. We should be aware of the rash characteristic and able to differentiate it from other common conditions that we see in our daily practice. And whenever we are seeing patients, suspected patients, we should adhere to contact and droplet precautions. We should be doing the needful in our day-to-day interaction with anyone with a rash. And it is a self-limiting disease, and supportive care is the mainstay of therapy. Thank you.
Thank you so much, sir. Thank you for the important session on the clinical aspects, how to differentiate between the rashes, as well as what are the explicit symptoms for the Mpox, as well as the available treatment modalities and prevention aspects. So it was very useful for the clinicians who are participating in this webinar. So thank you so much, sir. Now we move on to the next speaker. Our next speaker is Dr. Pragya Yadav. She is scientist chef at ICMR and heading the National Institute of Virology at Pune. Ma'am is wide experience in developing and helping in the SARS-CoV-2 virus indigenous vaccine, as well as she has the expertise in various important zoonotic diseases, and she is the winner of multiple awards across the country. So I'll request ma'am to talk about the diagnostics and laboratory aspects of the Mpox. So over to you, ma'am, for sharing the presentation.
Thank you very much. I'm not the director of NIV. I'm director in charge of National Institute for One Health. Please do correct that. Thank you very much for invitation today to share our experience on monkeypox. So as we all know that there is a alert, international alert, and that's why we all are here to discuss on monkeypox. But we all know that it was 2 years before it was alerted, and many countries work on preparedness. And India was also in the same race, and quickly we could do a lot of things, which I would like to share with you, and what protocol we are following for testing in the country. So as we all know that after 2022, WHO set up a target product profile for tests used for diagnosis of Mpox, and there is expert committee who work very extensively to define that how these assays can be used and what should be criteria. Recently, we could see that quickly Ministry of Health and even Pradhan Mantri Modi sir, they have taken update on monkeypox, and it was quickly published and informed to the country that we are working on it, and there is nothing to worry because there is no so far cases of the new variant which for that the emergency is declared. So let me share first what India did in 2022 when it was declared as an emergency. So first we quickly developed a real-time PCR which can detect orthopox, as we heard from all the speakers about the family, genus, and monkeypox virus. So we have these 3 assays which can test orthopox, which can test different pox viruses in the family, then monkeypox specific, and then West African specific. We prepared the positive controls and stockpiled the primers and probes, and prepared the SOPs. In the meantime, we activated 22 laboratory after the training and sharing the reagents, and 13 laboratory were trained, but they kept on the hold. NCDC is also one of the laboratory for doing the test. Then then the questions which Dr. Manish has very beautifully defined, the differential diagnosis, how we can do for the clinical patients. Similarly, the differential diagnosis required for these samples. And we prepared different panels, and we also shared these reagents to VRDL facility, so that if the sample come negative, they can test for different other pathogens which were defined by Dr. Manish. Then there was even a request came from SEER, and being WHO Collaborative Center, we trained 7 SEER member states and shared the reagents with them, and they also started testing. So far, India has reported 30 cases from 14 July to August 24, and we have done a complete genome sequencing of all the cases, and it is available in the Gene Bank. We could also isolate the virus, and which help to do more. Initially, so if we talk about a diagnosis, that time we had real-time PCR. We also developed the NGS protocols, virus isolation method, and electron microscopy was done on the clinical sample and also on the virus isolates. Further, these are the laboratory which was prepared for the monkeypox testing. These are the SEER member state laboratories, and then different viral pathogen testing were immediately implemented, which include varicella zoster virus, HSV1 and 2 introviruses, and reagents were provided to do. So now totally in India, we have 35 laboratory, and initially these assays were in 3 different test tubes, which you have to do 3 times. So we merge all the assay, and now we have a 1 tube assay where we can do all together in single go. So it's a 1 tube assay which we are giving to all these laboratories. These are the list of 22 laboratory which was initially activated, and as soon as this alert has come, now 13 more laboratory are being activated. So in India, we have 35 geographically located labs where you can refer your sample through the IDSP if required for any testing. As very well defined by Dr. Manish, that monkeypox, chickenpox, and measles could be a confusing for clinician, and that's why we need to take the samples, and we have to test them whenever there is a suspected monkeypox cases. During these last 3 years, we not only tested positive for monkeypox, but we also found many positivity for all these mentioned pathogens, and which showed that with the clinical, we also need to do the specimen testing to find out the right etiology for the treatment of the patient. Buffalopox is another pathogen in the orthopox viruses, which is prevalent in India in different states, and Maharashtra is one of them. But first time we could also, and we have seen many cases in the past, and a larger outbreak reported in 2011, 2017, and in 2018, where you can see rashes on the people who are in very close contact of the animals like cow, buffalo, and then disease transmit to them. It's as it was defined that it's a self-limited disease and can be managed by the routine treatment for the similarly. So you can see some of the outbreak even extended to 185 cases, 166 cases. There were no mortality, but definitely is cause problems to the patient who suffer through these infection. And complete genome sequencing, isolation, and diagnosis assays also available for buffalo pox, which can be utilized. In 2023, when these monkeypox alert was there, then when we were testing for monkeypox, we could detect this buffalo pox case in Kerala, which became the first case of buffalo pox in Kerala, and genome characterization was done, and we could see which strain is circulating. So what I'm trying to put that if you have a laboratory in the place and they are actively doing so, you can also detect many other pathogen which is circulating in the same time. So this is a quickly summary that we have. We started in May 2022 the SOP development, diagnosis, sample collections, and immediately the guideline for management of monkeypox was released by Ministry of Health and Family Welfare, which is available on the portal, and then standardization of real-time PISA was done. We could detect the first case in the July, and then virus isolation was done. It was sequenced, and then initial two cases were detected from UAE, where they traveled to Kerala, and then it was tested using the orthopox and mpox cases. Then upscaling of the laboratories were done, and 31 laboratory was stated that time. The NGS sequencing was done quickly, and we found that it is a clade 2B, and it's called A.2.1 lineage. Using the virus isolate, we could develop a serological indigenous assays in an IV for detecting the IgM and IgG antibody in the patient. We also did animal pathogenicity study to understand how lethal or pathogenic these virus strain are there. And until Feb 23, we have 341 suspected cases from 24 state and UTs, and environmental surveillance of Mpox was done, and we had total positive cases so far till then 25, which included Kerala 10 cases, all are imported cases, and in Delhi we have 15 cases, which was from Nigerian community and imported cases. After that, we did many other studies, which included the seroprevalence of monkeypox, community-based transmission studies, and utilization response for those people who had passed smallpox vaccination, understanding the genomic changes, and also we are in a process to work with the vaccine candidate. So far, India has reported now, we count all 30 monkeypox cases, and in this process, we could detect 44 varicella zoster virus, 17 enteroviruses, and 2 buffalopox viruses cases. The monkeypox cases have 18 male and 12 female, 15 from Kerala and 15 from New Delhi. India is reported one case. It was a young adult and had encephalitis presentation. Out of these cases, 29 recovered discharge and one fatal cases. So if we can see that only 2 state has shown these cases, rest of the cases turn the positivity negative. So if we talk about the cases, so it started from July, and so far We can see a concentration in 2022 where we have large number of the cases, and then we have only few cases in 23 and 24. So if we look at the mean age of these cases which presented in India is 30 years, 1880 Indian and 12 Nigerian cases. The heterosexual contact history were reported in 18 and 18 denied, and a death case we don't have the information, so we don't know. And during the case detections, most of the cases presented either with the 3 or so. These are the numbers when they are detected. So that range from third POD to 15 and onward. We also looked at compile the symptoms of monkeypox cases in India in percentage wise, and you can look at that the down where we can see myalgia, fatigue, lymphadenopathy, fever, and vesicular pustules. These are the prominent symptoms in the cases, along with the other symptoms with the monkeypox cases. If we look at the lesion sites and the number and counts, so we can look at that genital, upper limbs, trunks, and face and lower limbs back. These are the prominent site where these they were found. And the vesicular pustular and vesicular pustular with crust were the higher number of the lesions was reported. Lymphadenopathy, non-tender form, and multiple site, which we could see that out of 30 cases, 26 cases had a lymphadenopathy, and which you can, and most of these is presented in inguinal area. So these are the symptoms and presentation. In country, in the current scenario, if the cases are presenting, if they have a travel history, which will be very important to understand, to relate to from which country they're coming. The suspected cases are person of any age presenting in a monkeypox non-endemic country with an unexplained acute risk, one or more, any of the symptom which was defined by Dr. Manish very beautifully. And then but they could be presented with no clinical picture, which we have seen with the monkeypox cases. And confirmed cases would be defined by meeting with the definition of either a suspected or probable case, and they are laboratory confirmed by monkeypox virus by detection of either sequencing or DNA real-time PCR. So the probable cases, a person meeting the case definition of a suspected case, have one or more of the filing coming, have the epidemiological link to a probable or confirmed case of monkeypox in the 21 days before symptom onset. They have a travel history, and then they have a multiple or anonymous sexual partner in 21 days before symptom onset, has a positive result of an orthopox serological assay in the absence of a smallpox vaccination, and they are hospitalized due to illness. A suspected or probable case for which laboratory testing of lesion fluid, skin specimen, or crust is negative, they would be considered as a negative for monkeypox cases. So the questions come, which biosafety level or risk group we should consider the monkeypox. So in 2022, when the monkeypox was declared, initially it was considered a biosafety level 3 risk pathogen. Later on, the advisory was given by WHO that the samples can be inactivated, heat killed, and they can be used. You can be using the SARS coronavirus PPE, which we used in the past. The sample can be handled and they can be tested in BSL-2 facility, but it has to be inactivated before you start doing that. But in the current risk and emergence of a new variant, which is lethal and having more risk toward to the younger population, the questions come what we consider, as it is a new clade and India is not endemic to this country, so we would still consider this a pathogen to be risk group 3 pathogens. And as we all know, as per the definition, we don't, and as presented by rest of the presenter, that we don't have any vaccine, we don't have antivirals present in country, and we do not have access of any vaccine so far. So still the risk group is high for us, and we do not have any exposure. We have a very high population of young adults and young children, and they are not having any immunity for the pox or the smallpox vaccination. So that's why we are at high risk. We can consider in that category. So the similar kind of personal protective equipment which we have used for COVID, that include gowns, coveralls, Tyvek suit, double pair of gloves, face shields, booties, shoe cover, head covers, N95 mask if you are working in a ward where there is a patients are admitted. If you are in the lab, you are doing work in the samples, should be recommended for the healthcare worker when they are collecting the samples for the Mpox cases. So the questions come when to collect this specimen and what will be the right time for the testing. So the lesion roof, lesion fluid, and lesion base, lesion crest, these are the some of very high positive samples for monkeypox. Lesion roof should be collected with scalpel or plastic scraper. Lesion fluid with intradermal syringe. Lesion base scraping with sterile polyester swab collected, and the blood can be collected in SSG tube, and the post 4 weeks the some blood can be collected during the recovery phase to understand the antibody positivity. When we are collecting the lesion, it should be collected from multiple sites, and lesion samples should be collected. Samples can be collected either in tribe tube or in the VTM tubes. So in 2020, there was a lot of discussion, should we collect in VTM or dry plate? There was experimentation done, and it was found out that both way we can test and we can get the positivity. So if it is the cases are in the rash phase between the week 2 and 4, so we can collect the these samples, which is lesion roof, lesion fluid, lesion base, lesion crust, and but a country like India where it is not endemic, we also need to look at the differential diagnosis. So we can collect NPS, OPS, which is nasal fluid, and also the oropharyngeal swabs, blood, and also urine in sterile container. They can help us to understand if there is any other etiology present if it turned to be monkeypox negative. So the WHO recommend collecting the lesion materials, including swab of lesion surface, roof from more than one lesion or lesion crust, and always 2 lesions of the same type should be collected in one single tube, and preferably from different location on the body. Lesions, crust, and vesicular fluid should not be mixed. They should be collected in different tubes. And in addition to lesion samples, the collection of oropharyngeal swab and nasopharyngeal swab should be encouraged, because they also very good samples for testing and getting the positivity of monkeypox. So these are some of the pictures. So you have to sanitize the lesions, then remove lesion roof, brush the lesion brush, and then you put the swab in container, and then put roof in container. So you have to collect them separately. Then further you sanitize the lesions, remove the crust, and then you put crust in containers. So you will require alcohol wipes, sterile skull plate, lancet, plastic scraper, and needle to do this process while collecting the samples. The questions come if you are not in a zone where there is a laboratory nearby, so you need to ship the samples to the close by laboratory. You can use the WHO ITA updated guideline. In the ministry guideline also, this is very clearly written how to do the sample packaging, collections, and the shipment. We follow the triple packaging method, which we did for the COVID sample testing and shipment. Suspected clinical samples to be shipped as a category B biological substances, because these are the suspected samples. They are not confirmed samples. They will label as a VUN 3373. So it's a category B biological substance when we are putting the forms, and we have to follow the instruction 650, which is PI 650, and no biohazard label or DGD form is required for such kind of samples testing. So the questions come why we have to be so much cautious about transport, why we have to do the biosafety. As we all know that you need to protect the sample, patient, yourself, and also the environment. And field specimen can be dangerous. If the people are coming from outside, we know, we have learned by hard way that emerging infectious diseases are reality of the day. It could be monkeypox, and it could be any new pathogen, or it could be anything. So we have to be cautious, and they can cause disease by aerosol route. They can be stable in aerosolized form, and they can be difficult to diagnose or treat. And some can lead to the person to person transmission. So to avoid these mishaps, we have to be taking precautions each steps. So these are the some of the images which I would like to show you quickly, that how you can use the laboratory material in the hospital to collect the samples. So you have to wear the full PPE so that you can protect yourself and also to the sample. Then you collect the specimen, you put a proper label to each sample, and this seal the neck of the sample so that it doesn't leak. At the same time, you have to make sure that the label should be visible. Then cover the samples using absorbance material. In case if there is any leakage or breakage happen, then all the material gets soaked in. It doesn't transmit or contaminate other tubes with the first one. So we can use the cryo box as a secondary container, and we have to seal the lid of the box after arranging the samples using the cello tape. And then we can put a 50 ml centrifuge tube or similar kind of a secondary container to keep the samples in the box. Then we have to make the tertiary container. So before that, we have to use the Ziploc pouch and seal it, and then you put in the plastic container, seal the neck of the container using the tip. Then finally, you put in a thermocol box, and then you give very good cushioning and also the cooling. If we are aiming for sequencing virus isolation, then we need to maintain the cool temperature, and that's why we have to make the gel packs, and then we can hand over these pack to the courier. But prior to that, you also need to write the sender's address, contact number, consignee address, emergency contact numbers, the list of the packing, airway bill, and the value equivalent. So all these information need to be filled, and these samples can be shipped to BSL-4 facility at NIB Pune. And you can contact either me or Dr. Rima Sahai for sharing any samples. As we all understand, this is a new variant which we are looking here, and India has did not report any such cases. So the each sample need to be sequenced to find out if there is any such kind of samples has entered to our country, to alert the system and take the all precautionary measures. So if we talk about the sample processing flow chart, so we have to first register the sample in a database. Then we have to create the logistic for sample aliquoting, the processing of clinical sample. And as it is a DNA virus, so we are going to do DNA extraction, or we can also do the total nucleic acid. But if we do the DNA extraction, it will be better results, and sequencing results will be better. Then we can do the real-time PCR, find out if it is positive or negative, and then we can report to results to the concerned authority. So this will be a kind of a chart how we are going to do. So mostly because this virus present in body for very long time, and PCR would be a choice of the test. It's very sensitive, specific, and also the simplicity is very easier. If cases are presented in a later phase, when you cannot do real-time PCR, they can be done by serology, but there is no serology kit available in the market to do it. So it has to come to NIV for the testing, because we have this indigenous kit which can be utilized for testing IgM and IgG antibody. So quickly, I define how we are doing the testing. So the first test is to do the real-time PCR for orthopox genus, which mean that if there is any virus, either is cowpox, camelpox, buffalopox, monkeypox, present in the sample, they will highlight when you do the PCR, and you can get positivity. But if it turn completely negative, it means there is a very less probability that it is a pox genus of the virus. So if turn positive, then you can do monkeypox generic test, which will highlight if it is positive. And if it turned positive, then you can do another real-time PCR, which can differentiate between West African and Congo basin. If it is a positive sample at first lab, and in the first test, second test, immediately the sample has to be shipped to NIV, so that we can do the next generation sequencing on priority to characterize if the new lineage is there or not, and report to the government and everyone on very highest priority. If the sample is positive, that can be also utilized for virus isolation and further research. But at the same time, if the samples turn to be negative for the test 1 and test 2, it means we need to follow for other differential diagnosis and look for other possible pathogen which could be possible and presenting like a pox kind of a situation. So if we quickly summarize, samples to be collected, primarily lesions or OPS, NPS in plain tube, serum, EDTA, and urine. We required PP, which include gowns, N95 mask, head caps, booties, shoe cover, faces, and double pair of gloves, transportation of a specimen in triple packaging, and dry ice. Contact us before sending the samples. Please send an email if you are sending to any nearby BRDLs or to an IV, so that they are on alert. They are going to receive timely the samples. They are going to process the sample on priority. And then you can also do the WhatsApp communications, and you must share the images of the lesions, because that really help. If there is a good clinician, they can identify quickly if it is a monkeypox case or not. At the same time, we also need to understand, while doing the laboratory testing, it should be always done by people who are being trained. They know the biosafety practices, they know how to do the test, and they are having certified, they have NABL accredited laboratory, and they follow proper guideline. And the risk assessment of the laboratory should be done. The routine clinical sample from confirmed or suspected monkeypox cases should be able to differentiate. And as I mentioned, the PCR would be the preferred test for such kind of testing. Once you are done, either in hospital or in the laboratory, the decontamination of the surfaces is must. And after aliquoting the blood, serum, and all the clinical sample, they should be discarded using the hypochlorite solution or Lysol solution to take care that, as it is a DNA virus, is stable, and so you have to kill the presence of the virus in all the way. You need to dispose and decontaminate all the material who are come in the contact of the clinical samples, and then you need to discard all the PP, and then make sure that they leave the facility in a right hand for decontamination. The next questions come the genome of monkeypox, as it was mentioned by other. That is a double-stranded DNA virus, and it is one of the longest DNA virus which we see, and the pox viruses are the longest DNA. So if we compare with the coronavirus has only 30 kb genome. So you can understand how many fold big is the genome. It has a multiple open reading frame, and is a very complex bioinformatics expertise is required to evaluate and understand how much mutation is there, and to understand which ORFs is having variations, and which strain is circulating. So we need to do a good study once the data is retrieved. And getting the data is also a kind of challenge, because it's a very big virus, but it can be done with the right expertise and good protocols. So this is simple. I just wanted to say that there are many genes which is very, very important. But monkeypox virus contain at least 4 open reading frame in ITR regions, and vaccinia virus A27 proteins and is homolog, which are found in a large number of members of genome, are target of virus neutralization by host antibodies. So as it was mentioned that, and initially the virus was called as the West African Central African clade, which was relabeled in 2022, and now it is called the clade 1 and clade 2, or the clade 2 consists of 2 subclades, 2A and 2B, with the later referring primarily to the group of variants. But then further it has a subdivision, which I would like to quickly describe for you. So if we look at the monkeypox detections when we did, and we have done this phylogenetic analysis in India. So if we look at these sequences from India belongs to 3 subclades. It is called A.2, A.21, and we have done we have retrieved 22 complete genomes, and 13 are A.2, and 9 of them are A.2. So, which you can see here with the blue remarks, these are having very similarity with US, and presented in many countries. Similar kind of clusters are also found. So if we look at the lineage A2, which subcluster in 1 and 2, and further it's called as A.21 and A.2, it is present in India and in many other countries, but most of these cases either coming from Nigeria or from UAE, which I described earlier. And we have to look for the new clades if introduced in country as well. We also did a study with Dr. Vineet Rehlan and the Hospital for Delhi, where we could monitor the cases which were admitted for almost 1 month to see how long the virus is present in different body fluids. And we could see that monkeypox DNA was detected from 5th POD until 24th POD. The EDTA, blood, and serum were negative for all cases except 4 of them, and the CT value, means viremia, was very low, and which suggests that in blood the viremia is for a short time. The oropharyngeal swab and nasopharyngeal samples were positive in all cases, and they have a good viremia. The high viral load was detected in lesions fluid, urine, lesion roof, and lesion base, and also in the crust samples, including OPS and NPS. So this is a data-based study which I'm presenting here. The one case which was immunocompetent male in Kerala, and he died with the disease. The clinical features presented from the MRI for finding CSF pictures and EEG finding of these cases suggest encephalitis. We could only receive one sample, which was its oropharyngeal nasopharyngeal swabs, and based on that, this case was confirmed, and we could retrieve the genome sequencing of this virus, which was presented as clade2B, as like other monkeypox cases present in India that time. So if you look at the monkeypox cases which are present in India, and we analyze this ApoVEC3 mutation, which is a pathogenicity gene for the orthopox virus, and we can demonstrate there was 25 additional mutation which were detected in India, and which it is very surprising. Monkeypox supposed to be a double DNA strand virus and should be very stable. But in these years, we found in some of the monkeypox strain, there was 5 kilo bases, which is 5,000 nucleotide deletions were found, and there was some mutations, larger mutations were found, and which we can correlate with COVID, that in COVID, when it passes to larger population from one person to another, the mutations increase. Similar, in monkeypox also, the mutations are increasing, but at the same time, immunity and other parameters, host response is also playing important role in the mutation of the virus. This is a picture of monkeypox virus isolation, and which you can see these are some of the electron microscopy pictures taken in an IV by Dr. Basu that time. We could grow this virus in multiple cell cultures, and is susceptible to large number of the cell culture, and it can be adopted in any cell culture very easily. Further, ICMR released one expression of interest, because there were many companies who developed this assay and they wanted to have a validation to be done so that they can approach to CDCSO and they can get approval for manufacturing. So we had formulated a committee, made this clinical protocols and guideline for validations. We also find the sensitivity of assay panel of samples and tests were established, and multiple companies approached to ICMR, and many of them were they shared their 3 batches. They were tested, and the reports were given to them. And out of these 6, which passed the validation, 2 of them is being approved now from Government of India to be manufacturing as well. So so that is the one. So there will be more kits available in the Indian market for use. Then we developed this monkeypox human IgF ELISA. We did sensitivity specificity assay, and then we using this ELISA, we can look at the IgF and IgG antibody kinetics in human, and which could tell us that detection of anti-monkeypox IgG antibody started from 10th POD, and it keep going for a very long time. Regarding the IgM, we could follow the cases up to 30th POD, and they were showing a positivity. So then there is another study which we did with Dr. Vineet Lehlan in his team in the hospital, when there was 8 confirmed monkeypox cases were isolated. We could define this hospital bed, entry, exit, bathroom, everything in a very systematic order, and we collected specimens from 38 surfaces of the hospital, which include donning room, isolation ward, washroom, and doffing area. And we take these samples. We not only tested for PCR, but we also try to do the virus isolation from each. And we could see that except the doffing area, we could find the positivity in all the area, and some of the area, for example, nearby the bed area, bathroom area, the highest viremia was present, and we could do the virus isolation from these sites. So what I'm trying to say, why we did this study, to understand that whenever the cases are admitted in hospital, there is a huge aerosol and the live virus is present, and which can also lead to the hospital generated infections. And there was many studies done by CDC and US. They reported such kind of cases where health worker got infected when they were present in hospital. So I think this is my last slide, where I would like to give a very clear-cut message. Either you're working in a hospital or you're working in a lab, you're dealing with a patient or sample, the hand hygiene, which we learned very hard way in the pandemic, and mask practices are must whenever we are around to such kind of infectious area. And this is the only first and most way of protecting yourself this infection. But rest, it was very well defined by Manish, Dr. Simi, and rest of the speaker. So with this, I would like to thank the Kerala Public Health Authorities, Delhi Public Health Authorities from 22 to till now. Whenever there is a sample coming from these area, we work as a team, and in the coordination with the NCDC, in the leadership of Dr. Atul sir and rest of the members. And I would like to thank all of them. And from ICMR, I would like to thank Dr. Neetu and Dr. Nivedita Gupta, who are constantly working on monkeypox, and the BSL-4 team, Dr. Anita Rima, and many others who work constantly, and leadership of ICMR, for all the support during different outbreak response we receive and act when required. Thank you very much.
Thank you so much, ma'am, for this elaborate presentation on the diagnostic aspects of the Mpox. So thank you so much for this valuable presentation. Now I would like to invite the next speaker. I'll just introduce the speaker first. Our next speaker is Dr. Shubhangi Kulsange, Joint Director IDSP at National Center for Disease Control. She is having more than 17 years of experience in public health emergencies management and the program coordination, with the specialized interest in the tuberculosis HIV, and leading the multi-sectoral programs for the capacity building and surveillance at NCDC. Over to you, ma'am. I will move the slides from here if required. Ma'am, you can start.
Yeah. So you are sharing the slides?
Yes, ma'am. I will move. You can share me the next. I will share the slides.
I will prefer to share the slides. Yeah, thank you. Is it visible?
Yes, ma'am, visible. Only make it screen more. Yeah.
Yeah. Now it's visible in full screen?
No.
Ma'am, yet to, because it will be lag somewhere.
Please do it in slideshow.
Yeah, can you just confirm it is visible in the full screen?
Not yet, ma'am. Ma'am, once you can stop sharing and again reshare, it will help.
Okay, yeah, maybe just you go ahead with then sharing. Yeah. Yeah, thank you. So, my previous speakers have already like covered about the virus conditions, and also what I'm going to talk more specifically is about the surveillance of what we have proposed under the program. So just to because this is all being covered, WHO has declared this as a public health emergency of international concern recently. And we have a high level of meetings which Dr. Pragya has very well mentioned, and at high level meetings were undertaken, and all those were like the preparatory stage. To the next slide, please. This is all covered. Next slide. Yeah, so just to summarize the Mpox situation in India, so this was also covered by Dr. Pragya. The first case of Mpox was reported in Kollam, Kerala on 14 July 2022. And the last case was reported on 27th March 2024, again from the Kerala. We know that we have learned that we have reported 30 laboratory confirmed cases, and of which 15 were from Kerala and 15 were from Delhi. The case, again, age group was 22 to 48 years, affecting 18 males and 12 females. Nationality, again, 18 were Indian, however, 12 were from the African countries. And out of all these 30 cases, 12 cases have given the history of international travel. And among these cases, one death was also reported from the Kerala. So during the previous Mpox, when it was declared as a public health emergency, the primary modality was the passive surveillance. So it was a self-reporting which was being followed in India for the case detection. Moving to the next slide. So surveillance, what do we have? Again, we know these things. We've been doing this since long time now. Why do we do the surveillance? The key objectives, again, is to rapidly identify the cases and the clusters of infection, and as well as the sources of infection we would like to know, so that we can also provide the optimal clinical care in time. The isolation of the cases to prevent the further transmission, it is necessary, and to identify, manage, and follow contacts to recognize the early signs of infection. That will help us again to further prevent the transmission, to identify at-risk groups for the infection and for the severe diseases, and to protect the frontline health workers and tailor effective control and prevention measures. Next slide. Again, this was also covered, but I would like to again talk about the definitions, because this is these definitions are going to help us in the surveillance. So when do we call a case as a suspect case of Mpox? A person of any age having history of travel to affected countries within last 21 days, presenting with an unexplained acute rash and one or more of the following signs and symptoms: either swollen lymph nodes, fever, headache, body aches, profound weakness. We have already seen that fever may not be there, may or may not be there, but unexplained acute rash and the history of travel becomes our suspect case. In addition, the probable case, how we define a probable case: a person meeting the case definition for a suspected case, clinically compatible illness, and has epidemiological link. So how do we define an epidemiological link? Either there is a face-to-face exposure, a very close contact having the exposure, including healthcare workers without appropriate PPE. There is a direct physical contact with skin or skin lesions, including sexual contacts, or contact with contaminated materials such as clothing, bedding, or utensils, is suggestive of a strong epidemiological link. And how do we define a confirmed case? Is a case which is laboratory confirmed for Mpox virus for the by detection of PCR, that we have already seen discussed. Next slide. So The core strategy for the surveillance, again, we've been talking about the integrated disease surveillance program, and there are the district level surveillance units which are already being sensitized about this. So the entire surveillance activity has to be coordinated at the district and the state level through the IDSP program and the unit. What are the core strategies we follow for the surveillance? One is the hospital-based surveillance. Of course, the health facilities where like such as dermatology clinics, the STI clinic, the medicine and pediatric OPDs. This will be our primary focus when we are doing a hospital-based surveillance. So the patients walking into all these facilities with the classical symptoms of fever with rash and history will become our suspected case. The second strategy will be targeted surveillance. We've been talking about the route of transmission as a sexual transmission, and targeted intervention sites which are identified by the NACO program for the MSM, FSW's population, ICTC centers. They become our second core strategy for the surveillance. As soon as we are able to detect the suspects, as soon as we are able to confirm the case of Mpox, we have to start contact tracing. That becomes our third surveillance strategy. We need to find out the contacts and test them, and whether they are developing any symptoms or not, that we will have to further see. Next, please. Yeah. So what do we do again in the surveillance? Very basic things we have to follow. The standard case definitions, which we have just now seen, they needs to be followed by all the stakeholders, the clinicians, the physicians, the surveillance officers, they even the lab people, they will be following the same standard case definitions. Even one case of Mpox is to be considered as an outbreak, and that needs to be notified. A detailed investigation jointly by all the concerned stakeholders. As a rapid response team, we do this in all the outbreak conditions, and here also we will have to respond together with the concerned stakeholders. Report any suspected case immediately to the district surveillance unit, to the state surveillance unit, and the central surveillance unit. Send the samples as per the guidelines to the designated laboratories. Dr. Pragya has elaborately discussed about the laboratory network we have and the techniques which are being followed here. So we have to ensure when the surveillance is being undertaken, it has to be ensured. So all the DSOs and the state surveillance officers are being sensitized about the list of lab network which is available where the Mpox testing can be undertaken. So when we are doing the sample testing, particularly, we have to ensure that all these hospitals are aware about the sample collection and transportation techniques, and how to send the samples to the designated laboratories. So training of the people, concerned people who are involved in the sample collection, transportation, their training is also very crucial at this minute. Reporting of the cases to be done in the specified format, so that there is a format which is already available in the guidelines for the management of Mpox disease, which is there on the MoHFW site, and we have to use the same format for reporting. For suspected cases, again, one way of surveillance is, which is very important, is like if a community wants to report any suspected case, so there is a provision of reporting suspected cases on the IHIP reporting platform as well, so which can be very well used. Next, please. So when we want to do the contact tracing, we need to understand whom we will call as a contact. So a contact is defined as any person who has one or more of the following exposure with a probable or confirmed case of Mpox during the period of communicability. Communicability, we have seen that 1 to 2 days before the rash to until all the scabs falls off. The exposure can be face-to-face exposure, including healthcare workers without appropriate PPE, direct physical contact, including sexual contact, and contact with the contaminated material such as clothing or bedding, etc. So The first step when we want to do the contact tracing, but as soon as we have the confirmed case, we need to prompt all these cases to identify the contacts across the household, at workplace, school, nurseries, sexual contacts of the case, healthcare workers who are treating them, who have examined them, houses of worships where, the case might have probably gone, the transportation places, the sports, any social gatherings, and any other recalled interactions. So cases who are coming in contact with all these places, we need to find out. Then we have to monitor these contacts, so home quarantine and active follow-up for the contacts of confirmed cases. Self-monitoring is what we recommend at this stage for the contacts of probable cases. Contact should be monitored for a period of 21 days from the last contact. And in case of occurrence of fever or clinical symptoms, the lab confirmation is requested. Asymptomatic contact should not donate blood, cells, tissues, organs, or semen while they are under surveillance. So very basic preventive measures, we have talked about it. The first very foremost important point is raising the awareness of risk factors and educating people about the measures they can take to reduce exposure to the virus. Avoid close contact with anyone who has Mpox, including sexual contact. Avoid contact with any material such as bedding, clothing, etc. that has been in contact with a sick person. Clean your hands frequently with soap and water or alcohol-based hand rub after contact with infected animals or humans. Isolate infected patient from others. Dr. Manish has already talked about isolation strategies. Isolation precautions should be continued until all the lesions have resolved and a fresh layer of skin has formed. Use appropriate personal protective equipment whenever you are coming in contact with the case, and all infection control practices to be followed while handling the cases of Mpox. Next, please. Because there are multiple stakeholders involved, and one of the very important stakeholder will be NACO. So the surveillance at the NACO sites has to be initiated. At the point of entries, screening and controlling of the cross-border health threats. This already the advisory for the POEs in view of Mpox is issued recently, and we will be talking about that in the next slide. The hospitals and the clinics where these patients are probably visiting becomes our other key stakeholders. The states needs to designate a hospital for the isolation and sampling of the suspected cases. So every state nodal officers are already being informed. For the POEs also, it was informed to the state that they need to designate a hospital where the cases will be kept, alongside a network of designated labs for the diagnostic testing and data collection. So ICMR has already identified 35 lab network, which we have seen in the last presentation. We have to ensure that the sample transportation is done to the designated labs, and the people who are handling the samples are well trained. The lab and hospital needs to work in sync here so that the samples are reaching to the laboratories. Next, please. So yeah, this is the list of all 35 labs. This is already shared. Next, please. So at the point of entries, an advisory is issued by MoHFW on 20th August 2024. So it mainly talks about monitoring all international travelers from the affected countries at seaports or at land borders at POEs. We need to keep heightened suspicion for the suspected Mpox cases here. We have to do the isolation of all suspected cases at the transit isolation facilities, and immediately this type of suspected cases also needs to be reported to the district or the state IDSP officers. This suspected cases needs to be transferred to the designated hospitals. The sample of these suspected cases needs to be collected and referred to the designated lab. If positive, again, contact tracing needs to be undertaken. So authorities should be in a position to provide the list of all the contacts who might have come in contact with this case. Then use of self-reporting format for the suspected cases. So there is a self-reporting format which is being placed at the POEs. So any suspected case, a patient with the history of travel from the countries, African countries, and having the symptoms, they need to fill up this self-reporting format. Next, please. So this is the traveler self-declaration form, so which is expected to be filled up at the POE. It is available on the website also. Next, please. So very important aspect for the reporting of these Mpox cases, because we have been engaging the IDSP district level lab network. So all the PFORM users will be aware about how to report it on the portal. So the PFORM users, when they log into the portal, they will be able to see this format in which they will have to fill up the patient details, a very basic information which is usually captured here. Then in a clinical details for the provisional diagnosis, they have to click on the fever with rash option. So as soon as they click on the fever with rash option and click on, do you want to advise the lab test? If you click on to yes, then you will be able to see the test suspected for. Next, please. Next. So if the test suspected for, there is an option of, there is an option for Mpox. So once you select the test suspected for as Mpox, and the laboratory option will go as to external, and here all the 35 labs which we have seen so far are already listed down. So the PFORM user, any doctors who are seeing the suspected cases can actually link the patient for testing to the 35 designated labs. This will give us the information of all the suspected cases who are referred for the diagnosis, and this will be available on the IDSP IHIP portal. Next, please. Yeah, so these are just the links for the FAQs, and NCDC helpline number is given here for any further question. Thank you. This was my last slide. Thank you.
Thank you so much, ma'am, for the important aspects of the surveillance and how the doctors across the country need to look into the surveillance aspects and report the cases if they come across. So now we move on to the next presentation about the risk communication and the community engagement. I would invite the next speaker and share. Our next speaker is Dr. Meera Dhuria, Joint Director and Head Public Health Preparedness and NCD Division at NCDC. She is a public health specialist with more than 18 years of experience and contributed to the key aspects of the COVID-19 guidelines as well as the other infectious disease guidelines. And she is leading the IHR at the NCDC. So over to you, ma'am.
Thank you, Dr. Gutesh. I think having this session at the end makes so much of sense because all the stakeholders have been listed and what risk needs to be communicated to whom has already been covered, but still we'll move ahead with this. So as we all understand, we were using the jargon IEC, behavior change. So risk communication and community engagement is one part of that package in a new format. Risk communication is basically exchange of information between experts and vulnerable population to provide advice and opinions. And community engagement is to develop empowered relationships with communities as critical partners in creating workable solutions. And especially for diseases like monkeypox, which have a specific kind of a transmission mechanism. So what is risk communication? It is a form of dialogue in real time. And the main goal is that everyone at risk has guidance and facts which are needed to make informed decisions to protect themselves, their families, and communities from the health threats. And the context could be any channel, function, platform which can be used to communicate that risk. And it could be the doctor-patient communication. If we look at monkeypox, the doctor-patient communication after the self-reporting becomes very important. It could be either through electronic media like SMS, news media, social media, or newsletters or web series, and also IEC material, which could be the print material, and interpersonal communication. So we keep on giving our messages, but how do people perceive the risk and how those messages are actually accepted by the community? That depends upon the risk perception, which is the individual judgment about the likelihood that something bad will happen. So let's say we'll give example what Dr. Pragya, Dr. Shubhangi mentioned, that as soon as we heard about Mpox being declared as a PHEIC, then we perceived, okay, we have some risk. So as a country, we need to assess the risk. So we assess the risk based on the available data, literature, and also the briefings from WHO. And finally, we thought of communicating it with all the stakeholders. So what we are doing today through this webinar is also communicating the risk. So the perception about the risk is very important. However, this perception is a double-edged sword. If the perception is too high, there could be a lot of panic. And that is why risk management is the key. So this is just a picture to show how perception differs. So if you see from far, when you do not have the facts, it looks like it is a skull, picture of a skull. But when you see the closer picture and you have all the details available, so then we can see what the actual thing is like. That is why understanding the perception of the community or the stakeholders becomes very important. We need to communicate the risk, but we need to understand the risk, how risk functions. So risk is actually a function of a hazard. Hazard is the actual danger posed by any public health threat, and outrage is the amount of fear, worry, or concern people have regarding the public health threat, which is the perception. So based on our understanding of the risk, how people would actually perceive that risk or health threat, we need to communicate accordingly, and our messages and our channel of communication need to be accordingly adjusted. So this is just a type of risk communication which is required for the level of risk which is perceived. So if we see on the x-axis, we have the actual hazard or the health threat, and on the y-axis, we have the fear or the outrage. So if we talk of monkeypox, there are some stakeholders who are concerned about it. We all need to know what is my role and how this disease is going to affect us. But as we know, based on the transmission dynamics, we understand maybe the vulnerable population does not feel that risk and they will not come forward. So we need to undertake precaution advocacy also, which is shown in the lower quadrant on the right side, and on the left side lower quadrant we have the health education and the stakeholder relations. And what Dr. Shubhangi alluded before me was, like, we have sensitized our stakeholders, which are the points of entries from where the international travelers are coming from affected countries. We have also sensitized our labs, what has to be done, and we have had sensitization of all the healthcare providers. So that is, we are currently in this lower quadrant of stakeholder relations, where the perception of threat match the actual risk or threat, because we do not want to create panic. So based on the risk perception of facts, feeling, and fear, we need to moderate our risk communication strategy, and it should be based on trust, transparency, early response, listening, and planning. Risk communication will help the populations at risk to make informed decisions. I would just cite simple example. People are asking us whether we can travel to African countries or not. So if they have all the facts with them, it becomes easy. It will help them to have protective behaviors which are required to protect themselves, and will also complement the existing surveillance systems. Dr. Shubhangi mentioned that most of the cases reported were due to the self-reporting. mechanism. So for self-reporting, our existing surveillance mechanisms also need to be geared up. And when we have that kind of data coming in, like whether people were self-reporting or they were international travelers, we will also adjust our communication strategy accordingly. And also this will meet requirement for the coordination with health and non-health partners. As in health, we all understand we are not all communication experts, because communication needs to be done in a specific, specialized way so that the target audience actually gets to know what it is supposed to do, so that there is some change of behavior. And minimize social and economic disruption is very important, because if there is panic, or like what happened during COVID, and the same thing happened during H1N1. So if people are not aware what is available and what is not available, like the vaccines, the countermeasures, so this could also lead to some social disruptions, evacuations, and other problems. So building trust is required for the preparedness, response, and recovery from serious public health threats. I think all of us have gone through this flow chart. Like, how do we communicate the risk? There is a channel of communication, the communicator, what message has to be given, it has to be given to what kind of audience, and what would be the medium of communication, and what would be the final effect. So going ahead with this, first we need to define the audiences to be reached. So Dr. Jitesh mentioned that at NCDC, Director NCDC is the focal point for international health regulation. So once we understood that, okay, PHEIC has been declared. So as the government officials, we first reach out to our target audience, which is our senior government officials or the Ministry of Health, saying what kind of response we need to undertake. So that was first and the foremost audience which was defined. Then our sectoral partners like WHO would be providing us with some information. Then it is a zoonotic disease. So all other non-health partners need to be involved. If we have a disease, who will be bearing or who will bear that brunt would be the healthcare system and the providers. So they also need to understand. Media is very important, because these days it is the era of infodemics, and information is like either we have misinformed or we are disinformed. And the hospitality sector, because if we have international travelers, and most of people are also coming for medical tourism from many African and Middle East countries. So it is important to understand and also have them as one of our target audience. And last but not the least, the most important is the special or the vulnerable groups. And as we have understood the transmission dynamics by now, so the people, MSM, commercial sex workers, and even the doctors at specific levels need to be sensitized. So as I mentioned, the key messages for all the audience listed would be very different. For the decision makers, we will go with our plan of communication, and also what public health response needs to happen by which particular stakeholder. So risk communication planning and training is the most important part, which we will go and tell them. See, when this all happened, this was followed by press release. So press release actually built so much of trust for at the public level or for the general public, and for others also. Okay, the government is having a look at the ongoing situation. And the surveillance and surveillance reports form a key internal communication activity which will inform our external communications. So if we understand through our surveillance system what Dr. Pragya and Dr. Shubhangi mentioned, that most of the people who were tested positive during the last outbreak, they had some international travel history. So that becomes important for us, that our response and the decision makers are actually informed about this particular item, and the public health response or the communication happens accordingly. So with this communication, when we go to the decision makers, our public health advice is first and foremost given for the key stakeholders, like for integrated disease surveillance program, communicating the risk to them that they need to enhance surveillance. Then the points of entries, that they need to be a little more vigilant about international travelers, the healthcare professionals, so that if they have any suspect case, what they need to do. And this is released in form of advisories, guidelines, and SOPs. Then if we move on to our vulnerable high-risk groups, care workers, providers, healthcare providers, hospitality sector, travelers, and media. What do they need to understand is what is Mpox, how does the disease spread, how it can be prevented so that they can make informed decisions about their behaviors and the protective behavior which they need to undertake. How to take care of infected family members while protecting themselves, and also whether the vaccine is available, what are the other countermeasures. Our colleague from AIIMS already mentioned about it. What is the treatment protocol, treatment and diagnostic facilities available? Okay, because for self-reporting, this becomes very important because the type of disease which we have seen and the type of group in which it happens, it also we need to see that the messages must strike an appropriate balance of being informative as well as being specific to the high-risk population without cultivating stigma or excluding the people or groups which are potentially at risk, so that when they reach a diagnostic facility, the risk is being communicated to them at the same time. The similar kind of communication of risk also, or high index of suspicion, also needs to go back to the healthcare providers. And importance of self-reporting and healthcare seeking, because we need to be very careful while dealing with such patients and also providing them this information so that the stigma and discrimination is taken care of and people come forward for self-reporting, which is the mainstay. So the healthcare providers, Dr. Shubhangi already mentioned what is our surveillance strategy. So our healthcare providers need to be sensitized about keeping a high index of suspicion in particular cases, and the healthcare providers who should have this are dermatologists, the STI clinics, NACO, the centers, ICTCs, VCTCs, and also the medicine pediatrics departments. So accordingly, the key messages for them would be on the signs and symptoms and raising high index of suspicion. The treatment and management protocols, which have also been released by AIIMS recently, maintain the surveillance systems and reports in a timely manner. And the laboratory personnel, they need to be sensitized about the biosafety practices, which Dr. Pragya has mentioned, and also our field staff and our IDSP staff, because the sample collection and what precautions to take during sample collection, transportation, and even processing, that is very important. So they will, this population group will have key messages which relate to biosafety practices, and the housekeeping staff should be targeted for messages relating to infection prevention and control, biomedical waste management. However, for all healthcare providers and for community at large, infection prevention and control has a larger role to play. I think I don't need to go into the details of this, what kind of communication we all understand. We are in world of social media these days. So, but special events have a special mention because community engagement is very important for such a disease through some community leaders or peer groups, and engaging with the media and media management. Because the key messages, who would be the spokesperson, is the most important thing to deal with the media, and the key messages should remain consistent. That is why we are having a webinar, because if somebody asks us as medical professionals, what is the period of communicability? So all of us should have a same answer for anybody who's asking. So we need to emphasize on accurate reporting to prevent misinformation. And if the disease is new or the event is new, an expert's voice is important. Like recently, we had a press briefing or a press release in Times of India on FAQs by Professor Atul Goyal, our DGHS and Director NCDC, because he's an expert. So people would listen, and after reading through that article, they would have a clear picture of the disease, the situation, and the government's initiative on that. And communicating regularly becomes very important because the epidemiology is evolving every day. Avoid technical jargon and use clear, plain language while communicating with the media. And visuals would obviously enhance understanding and engagement. So, but what needs to be important for us as government officials and as the key people is social listening, because this social listening will actually help us adapt our media plans. So what are the myths? What are the things going on? This will all help us prevent misinformation, disinformation, and we will be able to manage the infodemics. So social listening from various sources becomes very important. What could be some of the consequences of poor communication is public panic, which can trigger mass movements, evacuation, breakdown. This is not specific for Mpox, but stigma and discrimination is one thing. If we start talking too much about Mpox, people would actually have the fear and anxiety, whether this already we are having some, I believe everyone of you would have come across questions like, are we going to have a lockdown? Is the disease transmissible like COVID? So these are really important questions for us to answer. Healthcare system stress, obviously, due to panic, people would like to have testing. They would like to, we will have so many other problems of RTIs and people flogging the OPDs for testing and other things. Then it would further lead to resource shortages and black market activities. Let's take example of any vaccine or drug available. This also happened during the time of H1N1. People wanted to hoard Tamiflu even if they did not have any case. So communication is very important, and that is why we need to have FAQs posted and also need to have a call center, which NCDC has already done. So for having effective risk communication, the timing is very important. I believe we have done it very timely. I would also like to inform everyone who has joined that WHO declared Mpox PHEIC on 14th of August, but looking at the global scenario, on 12th of August, NCDC already had a meeting on the risk assessment, because we perceive the risk, okay, that something is happening and something is on a rise. So risk assessment is important so that the appropriate risk can be communicated to the community and the stakeholders. Then trust and transparency. So this is, these are all the pillars of risk communication, the factual context, and invalidate the rumors. So there is a procedure of having, rebuttal for the fake messages and the fake news. Media monitoring becomes very important, and obviously the feedback. Feedback is through the social listening, which we do through the public information gathering. It could be through the social media, how many people are looking for drugs, vaccines for the Mpox. So this will help us have some targeted messages accordingly. So just to give a snapshot, which was also mentioned by my previous colleagues about the Prime Minister taking a stock of the situation, then the Union Health Minister already had taken before the Prime Minister. The guidelines for management of Mpox has been released and they are being updated. And the CD alert also, which was earlier released by NCDC in July 2022, has been updated and will be shortly available on the website of NCDC and will also be shared with everyone. So I believe that's all from my side. And this is the NCDC's helpline number for Mpox. This is the picture of NCDC. So all of you are welcome to visit NCDC. Thank you.
Thank you so much, ma'am. And this is a very important component of the risk communication, because we should choose to prepare over panic. So preparedness over panic is our key message that should take home, and all the clinicians and the experts available on this call need to address all the misconceptions and myths that may be circulated on the different social media channels or directly to you as a clinician, the patient, or the community is asking to you. So that is the important aspect that should be taken care. And this webinar is timely in that sense, so that we can address those queries in advance and we continue to be well informed through the various official channels. So now we like to take
one thing, Dr. Jitesh, I forgot to mention was about if we have any suspect case. So all of us should keep an eye on it and also report it to the national system, which will help us in managing it better. So this is for all of us, that we take care. First, we encourage everyone for self-reporting and then also manage it accordingly with the single point of reporting.
Yes, thank you so much, ma'am. Now we'd like to have the and what questions have been posted into the chat and question answer. We will look into those questions. We involve them in and circulate accordingly the FAQs, as well as involve the suggestions into the guidelines as applicable. And series of communications will be issued accordingly based on those questions and the queries into the chat as well as the question answer box. So we'll now move on to the end. So the poll will come again and you will have to take the poll so that we can understand and you can also understand how much we can gain from this kind of webinar so that we can plan such series of webinars subsequently. So the poll is live now. You may start answering the questions. The questions are same. Based on the understanding throughout the presentations, you can change or continue with your answer if it is correct. Requesting everyone to take the poll so that it will be helpful for you to understand and change the perception before the start of the presentation and now. So it will be helpful to communicate effectively to the audiences you will be catering to. So it will be helpful to understand what gained or over a period of time, and it will be also helpful to learn more things about that so that we can accordingly post those things on the website of the NCDC as well as the Ministry of the Health. So it will help us to understand the knowledge gaps so that we can proceed with additional information accordingly. So requesting a participant to take the poll.
So poll is still continuing. So we will end in another 15 seconds or so. But I take this opportunity to thank all the esteemed speakers who have taken the time, especially on the Saturday. So this is an extended weekend and many of us have planned to have some good weekend holidays. But still I thank Dr. Pragya Madam. She is Director NIOH and Madam is traveling somewhere, but still she has been kind enough to join us for this important session. I take this opportunity to thank Dr. Pavana Murthy from WHO. Sir was also very busy, but on the last moment, Sir has given his kind consent to give an overview of the global update. And I would also like to thank Dr. Manish Suneja from AIMS Medicine, and we really thanks her for a wonderful presentation on the clinical symptomatology. That was a very important session from the physician's perspective, that how we should differentiate among the various types of dermatological presentations and how the clinical index of suspicion is important for each or every physician from the reporting perspective. I would also like to thank Dr. Shubhangi Kulsange. Thank you so much, Dr. Shubhangi. I know you are traveling to your hometown, but still you have made it happen and given a very wonderful presentation. What exactly has to be the surveillance strategy? What is the case definition? How IDSP is responding to this PHEIC? And last but not the least, I would thank Dr. Meera Dhuria, Joint Director. Dr. Meera has given a wonderful presentation on risk communication and community engagement, which is of tremendous importance for a disease like Mpox, wherein numerous myths in the community, how to engage with the media, how to manage the misinformation and disinformation. Thanks, Dr. Meera. Dr. Meera is with me here at the NCDC only. And above all, I would like to thank our Director General of Health Services, Dr. Atul Goyal, who has given us the technical guidance, how to conduct, what should be the topics, and to what an extent this session is very important in the event of latest declaration of PHEIC by WHO. Thank you, sir. Thank you so much. And I would like to extend my sincere gratitude to Dr. Vineet Srivastava from Japaigo, who has extended his technical support to us, Dr. Vahini, who has helped us compiling the technical content, finalizing agenda. And I would also like to thank my team, Center for One Health, Dr. Jitesh, Deputy Director at Center for One Health, for overall coordination of the event. And I thank the participants who have shown a tremendous enthusiasm to join this webinar, and by the kind of participation which I am seeing and the reactions on the live stream as well as during the webinar, this is a real motivation for us to have such sessions in the time to come. Thank you very much. Thank you, everyone. Thank you, the IT team. Thanks, IDSP IT cell, for helping us on the back end. Thank you, everyone. Thank you.
And a big thanks to Dr. Simi and her team for letting this happen.
Thank you.
So,
Thank
all
you,
the
everyone.
participants.
Thanks. So we are ending this webinar. Thanks.
Bye, everybody. Thank you so much.
Bye, ma'am.
Thank you, ma'am. Thank you so much.